Assalamualaikum and salam sejahtera. Thank you for inviting me to give this talk at your conference. Just let me share my screen. Okay, I shall be talking about a neurologist's perspective of vertigo. What I'm going to do in this talk is to cover these topics, definitions, a bit of neuroanatomy, assessment of the patient with vertigo from our point of view, the causes of central vertigo, if you like, and then treatment of vertigo. Let's go to definitions. This is should be the same between ORL and the neurologist. Vertigo is a sensation of self-motion when no self-motion is occurring, or a sensation of distorted self-motion during an otherwise normal head movement. I usually use this definition, which is an illusion or hallucination of movement, is another way to describe vertigo. Dizziness, however, is very generic. It is now said to be defined as a normal sensation of impaired spatial orientation. But dizziness is also a layperson's term, and one has to define what it means from the patient's point of view. So it requires exact descriptions from the patient. Example, spinning, linear motion, swaying, tilting, staggering, shaky, veering to one side, or falling, and so on. This is important when you take the history. Vertigo, however, is not to be confused with lightheadedness or a sensation of impending fainting, what we call presyncope. The diagnosis is normally based on history, and the tests that we do are aimed at differentiating central from peripheral causes. Basically, central vertigo covers any lesion distal to and including the vestibular nuclei in the brainstem. Let's look at the neuroanatomy of vertigo. Firstly, just going to bring all of us back to this thing about balance. This is a bit broader than vertigo. So balance is controlled by four systems. The vestibular system being probably the most important. There's proprioception. You need vision, good vision as well, and the cerebellar function. So any one of these is disrupted, the patient will feel imbalance. And you have two of these gone. So a blind person having a vestibular problem, that will be a problem. So these are the connections important for the vestibular system and balance. Starting from the bottom, we have the spinal cord level and at the pontomedullary junction. Control the balance starts there with the relying on the vestibular spinal reflexes at these levels. Going further up, there are reflexive control of gaze during head and body movements by the vestibular ocular reflex, and this is mediated at the pontomesencephalic and cerebellar levels. So we're going a bit higher now. If you look at the pons, through the medial longitudinal fasciculi. And then there's perception of orientation and self motion and integration of voluntary motion, reflective motion and balance, control mediated at the cortical and subcortical levels. And this is mainly at the thalamus, okay? And then as we go to the cerebral cortex, higher function. So higher vestibular functions involves the multi-sensory integration and cognitive domains, such as spatial memory and navigation mediated mainly by the hippocampal formation and the temporoparietal lobes. So this is important in this area. So lesions anywhere in this pathway may cause either vertigo or dizziness in the broader sense. Right. I'm going to go to assessment now. So as a neurologist, we still do a complete neurological examination. We can't just examine the cerebellar function and some cranial nerves. That's not enough. I would even start with a mini mental state examination. Nowadays, we use the Montreal Cognitive Assessment, or MoCA, to detect mild dementia, subtle dysphagia, because these are surrogate markers for brain ischemia, which might suggest that the cause of the central vertigo might be an infarct or hemorrhage for that matter. So memory, cognitive function are also important in assessment of someone with vertigo. Then examination of the second nerve, looking for anisocoria in a darkened room. Why darkened room? Because we normally check for pupillary responses to light, but no one bothers checking this in the dark. If you don't do that, you'll miss failure of dilatation of the pupils in lesions involving the sympathetic nervous system. So someone with a Horner syndrome, you're going to miss the small pupil that fails to dilate in the dark. Right? So reaction to darkness is something that people normally ignore and forget to do. Fundoscopy is important because that might reveal papilledema. And as you know, the optic nerves are the windows to the brain. So there's papilledema that suggests a raised intracranial pressure as a main problem. And then you have to do a complete examination of the cranial nerves. So 3, 4, 6, looking for ophthalmoplegia. So someone with internuclear ophthalmoplegia or INO would suggest a midbrain lesion, which can also lead to dizziness or vertigo. Diplopia itself may cause dizziness. As I mentioned earlier, vision is important. So if someone has double vision, they may feel dizzy initially before they compensate later on. Then, of course, you will look for nystagmus while doing the extraocular movements. And then we move on to kind of 5, 7, and 8, because loss of corneal reflex is the earliest sign of a cerebellar pontine angle tumor. And hearing can be affected, and facial nerve palsy is a feature as well. Of course, one has to do cerebellar function and look for other long track signs involving sensory and motor function, because contralateral sensory or motor function in the body, contralateral to a cranial nerve lesion, would suggest a brainstem lesion. So cerebellar function, normally we would examine the gait, normal gait first, see how the patient walks. If the patient has an ataxic, broad-based gait, that might suggest cerebellar function, and look whether he tends to fall to one side or the other. Remember that it's important to look for the ataxia rather than the broadness of the base of the gait, because people can just walk with broad base if they're obese or if they have some other mechanical problem. So being broad base is not the key feature here. It's the unsteadiness, the ataxia is the thing that we're looking for. And also look at how they turn, and also tandem gait and heel to toe walking. That will exaggerate any cerebellar dysfunction. There's also something called the Fukuda walking test, where the patient closes the eyes while walking on the spot, and they may deviate to the side of a vestibular lesion. Dysmetrias can be seen in cerebellar dysfunction. So this is due to tonic imbalance of the vestibular system. So one would normally do a finger-nose test, rebound phenomenon with the arm stretched out, and then pressing quickly on one arm and see whether it rebounds, exceeds the baseline, looking for saccades, saccadic movements, and also looking for broken pursuit. I'll show a video of this. Speech, looking at the fluency of the speech, and also repetition of syllables, because someone with cerebellar function would have a dysarthria and unable to repeat single syllables rapidly. Also do looking for dysdiadochokinesia. So you do hand tapping and alternate with supination and pronation, and other things like drift, cerebellar pronator drift, and also the pendular knee jerk are optional basically, but they would add more support to the cerebellar dysfunction. So just look at this finger-nose test. I'm just going to show you how it's actually done. So the important thing is to make sure the patient stretches out arm's length, and you don't move your finger. You see, even with this, he's unable, he has dysmetria, he doesn't get to the target on the first go. This is dysdiadochokinesia, so you can do it rapidly. That's bad on the left. Okay. So this is rebound phenomena. So close the eyes and then just do it quickly. You can see the rebound on the left side and the right side too, I think, but not so bad compared to the left. So you've got bilateral cerebellar dysfunction. I'll just move on to some more. And then when testing eye movement, look at this lady. I'm asking her to follow my finger. So looking for pursuit, right? Normally we do this in an examination. We call it this H pattern, but really we're testing for pursuit of eyes in the eyes. So this is following an object. So this lady is following my finger. You can see that the eyes are jerking, right? This is called broken pursuit or saccadic pursuit, if like. You see, it's like got several checkpoints. She stops, starts, stops, as though there's a lag in the eye movement. I just play this one more time so that you can appreciate the broken pursuit. This is seldom done by doctors in the emergency department when someone has cerebellar dysfunction, but it's quite simple. It only takes a second or two to do if you do it properly. Okay. Next, this is called broken pursuit. Then we do look for saccadic eye movements. So look at a pen, look at my finger with an object placed laterally, and look at this chap. Okay. Tengok kanan.
Kiri.
Just play this one more time. Kanan. You see the overshoot and then coming back and adjusting. So this is called hypermetric saccades. If they undershoot, it doesn't reach the target, then it's called hypometric saccades. So both can occur in cerebellar dysfunction, and this is another form of dysmetria, right? So it's not getting the target accurately the first go. I just show you an MRI of a case that we saw recently. This was a 34-year-old male physician who presented with sudden vertigo and unsteady gait. He complained to me that he had tendency to fall to the right. He was treated elsewhere in another hospital by the ORL team as benign paroxysmal positional vertigo. His gait was normal, but he tended to veer to the right, very subtle, these things. But he had hypometric saccades, similar to the guy just before this slide, although that guy was hypermetric, so he had clear hypometric saccades, and that was the only sign that he had that suggested cerebellar dysfunction. So I proceeded to do an MRI, and this is the scan. He had a brain CT at the other hospital, which was reported as normal. I had a look too. So as you know, brain CT is not good at looking at the posterior fossa because of the bony artifact. So if you look at the arrows pointing here, this has gone for publication, by the way, so it's in press. Well, it's being considered for publication. So the top left panel, a T2 weighted axial MRI. If you look at the black arrow just pointing downwards, okay, that's the fourth ventricle, and the white arrows show an area of hyperintensity in the right cerebellum. Remember, he had tendency to fall to the right. It's also shown in panel B, and in C is a T1 weighted image where it is hypo-intense. The MRA was otherwise normal. Must remember that this scan was done about maybe 2 weeks or 3 weeks after the onset of his vertigo. So this gentleman, this doctor, had a cerebellar infarct presenting with sudden vertigo and unsteadiness of gait, and it was missed. So if you don't do eye movements properly, you don't assess cerebellar function properly, you would miss an infarct. And imagine this doctor, if wasn't diagnosed with this, he wouldn't have had proper treatment. In fact, when we proceeded to do an echocardiogram, not only did he have this stroke, but he also had, so 1 month post-COVID, I'll come back to COVID later, I forgot to tell you about this. He had an incidental finding of a PFO, a persistent or patent foramen ovale, shown by the thick arrows there. I know you can't appreciate this. It's better seen on real time, in real time. So I forgot to mention that this doctor actually served in Sabah and developed COVID while looking after patients with COVID at that time. And he developed the stroke after he returned to KL to serve here. So this is post-COVID cerebellar infarct with superimposed PFO. I suppose he was already prone to get stroke because of PFO, but PFO strokes are low prevalence, so most patients are not on long-term antiplatelet or anticoagulation treatment. But after you get another risk factor like COVID, as you know, COVID is a prothrombotic state, he developed the stroke. So this is going to be published, hopefully. And you must remember that these patients with cerebellar infarct may present with subtle findings, so that we must assess the patients properly in the emergency department or in the clinic. Let's moving on to the Dix-Hallpike maneuver, which is done more often in your clinic. So we use this to differentiate between the peripheral and central cause of vertigo. So in the peripheral vertigo, there tends to be a latency in some patients up to 40 seconds before you get nystagmus or the symptom reproducing the vertigo. Whereas there's no latency in central cause of the vertigo. The nystagmus and the symptom will come immediately when you do the procedure, when the head goes below the level of the bed, turned to one side. Duration is less than a minute in peripheral vertigo, whereas it's throughout the test. So as long as the patient's head is held below the level of the body, the symptom and the nystagmus will be there. How about habituation? Meaning that if you repeat the test, eventually in peripheral vertigo, the nystagmus and the feeling of vertigo will disappear, whereas in central vertigo, there's no habituation. Nystagmus that happens during the test is always fixed in the direction, so the fast component is always to one side, whether the eyes are turned to the right or left. It can be torsional, up, and upper pole of the eyes towards the ground. Yeah, so vertical, horizontal, and rotational nystagmus may occur. Whereas in central vertigo, the nystagmus is usually horizontal and it is variable in direction. So I will show a video of this again later. The intensity of the vertigo is severe and marked with nausea and sometimes vomiting, marked in nystagmus in peripheral vertigo, and in central vertigo it's milder, and also the nystagmus is not so bad. You can reproduce it all the time with central vertigo. This Dix-Hallpike maneuver, whereas it's inconsistent in peripheral causes of vertigo. There's another assessment which I'm sure you know. It's called HINS plus, right? So HINS stands for HI is head impulse, N is nystagmus, T is nystagmus type. T is test of Skew, or so that's called Skew deviation, and then plus acute hearing loss. So that's the plus part, by just rubbing your fingers against next to the ear. So this test is supposed to be a better test that would accurately rule out stroke earlier than MRI. But I must warn you that MRIs are getting very sophisticated now. One can detect MRIs, brain infarcts quite early in MRI, probably before the HINS can be done. So this is a bedside 3-part oculomotor examination. However, HINS only applies to patients with spontaneous acute vestibular syndrome or spontaneous episodic vestibular syndrome, while the patient remains acutely symptomatic, including spontaneous or gaze-evoked nystagmus. HINS should not be relied on in patients who have other syndromes, particularly those with triggered episodic vestibular syndrome, where normal head impulse test results could erroneously imply stroke in the majority, with actually benign paroxysmal position of the type. So this is the HIT test, or the head impulse test, or vestibular ocular reflex test. So in a normal patient, you ask the patient to look at you, and then you rotate the head quickly to one side, and you see that in a normal person, the eyes will still be looking at you. In an abnormal VOR or head test, the patient there's a lag. So the patient, when you turn the head to the left, for instance, to your left or his right, the eyes will follow him, right, to the right, his right, and then slowly come back. So that's called a corrective saccade. So that's an abnormal VOR. So let's show you the video in this man. So look at me.
That's right.
See, there's a bit of lag coming back. So this is slow motion. Look at me. He still looks to the other side, then he slowly comes back. There you go. So that is an abnormal head impulse test. And then we have looking for nystagmus. So peripheral lesions. Yeah,
you just keep looking straight at that red light.
Look straight. You just look, the fast component
look there. Yeah, that's great.
To the right, to his left.
Now, what I want you to do is look to the right.
So even though he looks to the right, there's not nystagmus there.
Now look to the left.
Now look to the left. It's still fast component to his left. So this is fixed direction nystagmus. Let's look at something with a direction changing nystagmus. And this is the central region. So look at the station. It's got a bit of strabismus. You can see fast component to his left.
Okay, now look to the left.
Look to the left, more to the left, still to the left. It's, okay. But now look to the right.
Look straight.
So this is not much nystagmus, but going to the right.
Look to the right.
Now looking to the right, the nystagmus is to the right now. So the fast component to the right is changing
straight,
depending on which direction you look. So this is changing direction nystagmus. Now test of skew with the cover test. So you can use your finger, your hand, the palm of your hand, or this eye blocker. So you alternately cover each eye while the patient fixes on an object. Like this man is using a torch. He can also focus on your nose, and we are going to observe for vertical corrective saccade, right? So this is consistent with the central lesion. So look at this patient. Listen to the instruction.
Look at the camera.
Look at the camera. So just there you go. You adjust. Yeah, I'll just play this back so that you can see.
Look at the camera.
You just let you see the right eye goes up when he uncovers the eye. It's a bit of deviation. This the eye as well on the other side. So there's adjustment. In a normal patient, it shouldn't change direction. Okay, so a summary of this hint comparing the peripheral vertigo compared to central vertigo. So with the head impulse test, in peripheral vertigo, there's loss of eye fixation with the head impulse. So this is called a positive or abnormal test. So there's a delay in the patient bringing his eyes back to the point that you want him to fix on, like your face or an object. Whereas in central vertigo, this is intact. It's called a negative head impulse test. It's a bit confusing, but this is negative, means it's normal, right? What about the nystagmus that you see? So usually this is spontaneous nystagmus. So with peripheral vertigo, there's either no nystagmus at all, or it's horizontal. And when there is nystagmus, it's unidirectional, whichever way the patient looks or fixes his eyes. In central vertigo, however, the nystagmus can be vertical, rotatory, or horizontal, and it is bidirectional, meaning the first component can be to the left while looking to the left, and then first component to the right, looking to the right. And the test of skew, the one with the cover test, so in the peripheral vertigo, there's no skew. Now this now is called a negative test, no skew. So it's normal, right? Whereas in central vertigo, there's a skew with the eyes, there's a corrective saccade upwards, and that's called a positive test, which is abnormal, right? So just remember that skew is abnormal in central vertigo, whereas in peripheral vertigo, the head impulse test is abnormal. Right. As a neurologist, these are some of the investigations we would do, but the investigation will be guided by the symptoms and signs and the clinical diagnosis. We don't do all the stats. It depends on what we think the most likely diagnosis is. So in many patients that come acutely as an inpatient, we would do a full blood count, looking for anemia, hyperleukocytosis, polycythemia, because these things may predispose to an infarct, right? Anemia, because if you don't have an oxygen carrying capacity, if someone has a TIA, the chances of converting that to a complete infarct is going to be higher. Whereas you have too many white blood cells and too many red blood cells, because it becomes hyperviscous and you can get an infarct that way. And of course, we do an ECG as well to make sure there's no arrhythmia, myocardial infarct, or myocardial ischemia that will predispose the patient to a brain infarct. And then we look for the risk factors for diabetes. We do an echocardiogram just as the patient we did before, looking for a valve lesion, a thrombus in the left ventricle or left atrium, and also PFO. Carotid Doppler, carotid stenosis is optional. Well, not optional. We do it in patients with an anterior circulation stroke, like middle cerebral artery or anterior cerebral artery infarcts. Ambulatory ECG if needed, right? So if you strongly suspect that this patient has atrial fibrillation or an arrhythmia, then you need a longer ECG, and an ambulatory ECG would be a useful one, just not a 12-lead ECG once. We sometimes, and this is rarely done, we do an EEG to look for supportive evidence for temporal lobe epilepsy. I'll come back to this later because TLE, temporal lobe epilepsy, can cause vertigo. But one must remember that an a normal EEG does not rule out epilepsy, right? But if we get epileptic spikes or sharp waves during the EEG, that will be supportive evidence for epilepsy, particularly if the spikes and sharp waves occur in the temporal lobe, over the temporal lobe. Brain imaging is mandatory in all cases of central vertigo. You must do that, okay? If all the tests, all the assessments point to a central cause, we have to look for the cause of it. And this cause may be fatal. So preferably MRI or a CT angiogram. And we do this following the stroke protocol. And this is done in most teaching hospitals and public hospitals as well. So going to causes. So the symptomatology of central vestibular disorders is often vague, right? Because of the many various features that accompany depending on where the lesion is. So that's why we look for other neurological signs, including hearing, auditory testing, brain imaging mandatory, as I mentioned, if chronic. So this is someone who's come not acutely like this now, but if it's chronic, you would do, or if they fail medical therapy, even if there are no other neurological signs. These are some of the common causes of central vertigo. I won't touch on all of them. So brainstem ischemia or infarction, tumors, arteriovenous malformations leading to hemorrhage, vestibular and basilar migraine, which is covered in another lecture by me. CP angle tumors, I won't cover here. Seizures, I will talk about a bit. And of course, 10 to 15% of patients may have a psychogenic cause of vertigo. This is put under central because it's, supratentorial. And there are other causes which I won't go through. So central vertigo is far less common than peripheral or systemic causes. Must remember that. And patients often have this disequilibrium or equilibration or imbalance rather than vertigo. So even someone with cerebellar infarct, like that doctor that I presented, he didn't have vertigo, he had imbalance. He tended to fall to one side. So some would say this is like dizziness. If pathological, right, is usually accompanied by other neurological symptoms and signs. Usually, so like that doctor, he had this hypometric saccades, but was missed in the first time by doctors somewhere else. And cross symptoms and signs suggest a brainstem lesion. I mentioned this earlier. So if you have, let's say, a 7th cranial nerve palsy, lower motor neuron type on right side, and then a left hemiparesis or left cerebellar signs, that would be suggestive of brainstem lesion if they cross. Right. Let's look at brainstem ischemia. So I'm just comparing acute peripheral vestibulopathy compared to a brainstem or cerebellar infarction. The nystagmus is away from lesion, the maximum nystagmus in a peripheral vestibulopathy, whereas it's towards the lesion in a brainstem infarct or cerebellar infarct. Fast component is away from the lesion, even upgaze, and is unidirectional as mentioned earlier in a peripheral lesion. In a central lesion, it's towards the lesion, but variable in direction or bidirectional. The fall is towards the lesion in acute peripheral vasculopathy and also towards the lesion in a brainstem or cerebellar infarct, as in the case I showed. There are no other ocular findings, should be no other ocular findings in an acute peripheral vestibulopathy, whereas in a brainstem or cerebellar infarct, you can get INO, 1.5 syndrome, and limited vertical gaze. So let's look at this patient. She had bilateral internuclear ophthalmoplegia. So looking to the right, you can see that the right eye is okay, able to abduct, but the left eye is stuck in the center, unable to adduct. Look to the left eye is able to abduct, but the right eye is now stuck in the center, so unable to adduct. So this is bilateral internuclear ophthalmoplegia lesion in the midbrain, right? And the patient's vertical gaze, however, is normal, looking up and down. Only the horizontal gaze. So this patient, let's look at her. Kanan, kanan.
Tengok kiri. Tengok tengah. Tengok atas. Tengok bawah. Pandang kanan balik. Dan pandang kiri. Okay.
So this patient, the right eye is completely fixed horizontally, cannot move right or left, cannot abduct or adduct, whereas her left eye, right, is able to abduct but cannot adduct. This is called 1.5 syndrome, and I don't have time to explain in detail, but 1.5 syndrome means there's involvement of both the paramedian pontine reticular formation and the medial longitudinal fasciculus on one side of the brainstem. So this is 1.5 syndrome, and the patient has vertigo. It's almost always an infarct in the pons. Let's look at lateral syndrome. This patient again was missed in the emergency department. It's a bit dark. She's got ptosis. Look at it, right? The left eye, partial ptosis. And there's meiosis. It's difficult to see, but the left pupil is smaller. Look, the deviation of the soft palate to our left, but to the right. See, going to the left. Okay, so that suggests she has weakness of her left 10th nerve muscles supplied by the 10th nerve for palatal elevation. Okay, so she's got left meiosis, left partial ptosis, left 10th nerve palsy, and she also had left cerebellar dysfunction, whereas right hemianesthesia of her body, and also left, fifth nerve involvement. So she has a left lateromedullary syndrome. And patients who are, fair skin and with light colored iris, it's easier to see, look for meiosis like this lady here. She's very clear, the left eye, her left eye is partially toast and also has meiosis. So this is a bit more difficult when the iris is darker in such a patient. So the patient that I showed you had an infarct in the medulla, the lateral part. I know you can see this, I can't point with the arrow, but the medulla is, you can see this coronal view, there's a white or bright spot in the at the bottom there of the medulla. So the patient will have acute vertigo as a symptom, vomiting and dysphagia. Typically, they are hypertensive and usually not taking their medication. There's ipsilateral Horner syndrome, 10th cranial palsy, spinothalamic facial sensory loss, and cerebellar dysfunction. And by contralateral spinothalamic loss, sensory loss of the body, as I mentioned earlier. Seizures, let's go to TLE. Let's look at this 28-year-old man at that time. Sorry, I didn't mean to play this, so we won't play that video, but patients with TLE may have vertigo as either the aura, that means the warning sign before they get the attack, and then they would, so this man would have dysfunction, a dystonia of his right arm first, suggesting that the left temporal lobe is firing away with epileptic discharges. And then he would have automatisms with his mouth. He will be chewing like this, and then lip smacking, right? Sometimes swallowing. And he will be unaware, unresponsive, looks dazed, right? And then he would also have what we call automatisms with his left hand doing this twinkle, twinkle, little star. This is called automatisms as well. So automatisms and this dystonia on the opposite, or the side opposite the lesion, are characteristic of what we call a complex partial seizure. Now it's called focal unaware seizure of temporal lobe origin. So if someone has vertigo and you suspect epilepsy, ask these questions about from the caregiver, the eyewitness, how did the seizure start? They might generalize, become tonic-clonic, but some patient only has this complex partial seizure or focal unaware seizure. In terms of treatment, so basically we treat the underlying cause, right? So if it's an infarct, patients may benefit from thrombolytic therapy, right? And sometimes from medical thrombectomy. And as you know, time is brain, so every second counts. Diagnosis must be made quickly in the emergency department and then refer to the stroke team. And the patient, if it's within the first 4.5 hours of the symptom onset, can be treated with thrombolysis with recombinant tissue plasminogen activator, RTPA. So the therapeutic window is 4.5 hours, and it is important to get the scan, at least a brain CT, better still CT angiogram of the brain to look at the perfusion. So, but nowadays the gold standard is to do an MRI, where we can look for perfusion diffusion mismatch, right? A diffusion MRI will show that if it's abnormal, means the infarct has occurred. But if that's normal, the DWI, the diffusion weighted imaging, compared to the PI, which is the perfusion imaging, let's say perfusion is already absent, means the artery is blocked, but DWI is still normal, there's an opportunity to thrombolyze. That means the infarct has not occurred, but there's already ischemia. But if there's a match, the PI and DWI match, that means the infarct has occurred, no point giving the RTPA. So that's better than the 4.5 hour window. Right? Some patients may come earlier, but they already have had a full infarct. Right? But maximum time, even after that is dangerous, even though there is a mismatch, meaning the infarct is not full blown yet. So remember the 4.5 hours. And nowadays we talk about door to needle time. So door emergency department, needle the time to give this RTPA. The gold standard, the good gold standard would be a 1 hour, right? Or 90 minutes would be the best. The earlier you give, the better the outcome. So it's important not to miss this in the emergency department. And of course, some patients will require symptomatic relief as well. So even though we have given that treatment, the patient may need a medication to relieve the vertigo. And some patients, the infarct goes through, so or there's a hemorrhage, you have to refer the patient to a vestibular for vestibular rehabilitation therapy, or VRT. So I'm just going to summarize this because since we are worried about stroke, the main issue here, in someone coming with an acute vestibular syndrome. So nowadays, if it occurs less than 24 hours, but really TIAs usually would resolve within an hour. The new definition TIA is going to come out soon. It's not going to be 24 hours anymore. 24 hours is plugged from the sky. It's not in the Quran or Bible. So it's going to be probably 1 hour. So if you look at these risk factors, right, if the patient fulfills these risk factors, then the chances of getting stroke in the future is higher. So there's something called the ABCD2 trial, because there's ABCDD, so it's double D, age, blood pressure, clinical features, duration of symptoms, and diabetes, and you give points for this. So the patient is older than 60 years old, 60 years or older, you give a point. Blood pressure is high like that, give 1 point. If there's unilateral weakness already, you give 2 points for that. Speech impairment without weakness is only 1 point though. Okay, so that's one group together. So the total is, if you calculate that, would be 10 points, right? 2, 4, 6. So that would be 1, 2, 3, 4, 5, 6, 7, 8 points in maximum. So diabetes is 1 point. Duration of symptoms more than 60 minutes is 2 points, whereas if it's less than 60 minutes, 1 point. So the total maximum is 7 points. So if we have 3, right, 7 points for the ABCD2 plus 3 points for the imaging abnormality. So the total is 10 points if you combine the clinical features plus the imaging. So if the score is high, meaning 6 to 7 or more, then it's the risk of recurrence of TIA or stroke, is within 90 days, 3 months, it's 8.1% compared to if the score is lower, then it's only 1%. So if it's less than 3, it's only 1%. So this is how we would stratify patients with TIAs. And you can find the guidelines for the management of ischemic stroke in our Malaysian Society of Neurosciences website. The website is listed here, www.neuro.org.my. And this is a 2020 edition. And I was involved in the review of these guidelines. I'm not an author, but they asked us to review. Okay. All right. So vertigo, if it's summarized, you ask yourself whether it's episodic or acute vestibular syndrome. If it's episodic, whether it's triggered or spontaneous. And if it's triggered, you do the Dix-Hallpike maneuver. If they get a typical nystagmus, it's a peripheral lesion. If it's atypical nystagmus, that bidirectional, rotational, or vertical, it's a posterior fossa lesion, so it's central. And you need a brain MRI. If it's spontaneous, it comes out of the blue, take a good history, a migraine history, whether it's vasovagal attacks, kind of history, or TIAs, whether ABCD2 score is more than 3, or Meniere's disease. If it's an acute vestibular syndrome, it could be trauma or toxic, and you take a history to define that, whether it was whiplash injury recently, sorry, the spelling mistake there, head trauma, and drugs. If it's spontaneous, then you do the HINS test. That's the one that I went through in quite a bit of detail. So if it's if it responds to peripheral, you get the ORL specialist to see. Whereas if there's no nystagmus, no ataxia, and normal extraocular movements, you refer to the neurologist or medical team to find out what the hell is going on. And then if it's a central cause based on the test, most likely it's a stroke if it's an acute problem, or an encephalitis. So that's a summary for my talk. And if it's a stroke, of course, you refer to neurologist, or if it's an encephalitis as well. Okay, thank you very much for your attention. Right.